All right, good evening everybody and welcome to the GPCE MEDTalks, and I say that to both all of you who are in the room and also the people who are watching online, because this is going live on the internet, so as people in all corners of the country hopefully be watching. My name is Joe Kostrich. I'm a GP in Perth and also on the organising committee for the GPCE and the MEDTalks. So tonight we're going to be talking about biologics, which is a big and an expanding and very rapidly expanding field, as we're going to find out. And we have four speakers from very different backgrounds who are going to give us a number of different perspectives. First off though, before we go a little bit more to that, a little bit of housekeeping. You don't actually have to turn your mobile phones off, and I'll explain why in a moment, but please put them on silent so that they're not ringing in the middle of the talk. No flash photography, as usual for the obvious reasons. But you can use your mobile device to ask questions by going to slido, slido.com. If you go to slido.com, open it up in your browser on your smartphone, or for those of you at home on your computer or your other device. Enter the hashtag MEDTalks, MEDT in capital letters, T capital, talks, and then put your question in, because at the end, after we've had the four talks, we're going to take questions both from the floor, and if you want to put your hand up and ask questions, obviously you're welcome. If you're shy, you don't need to be, but if you are, you can put your question in via Slido and we'll collate those, and obviously for people online as well. So biologics are not quite as new as we think. They've been around for a little while, but they're a class of medications that I suppose are unique in that they're not quite a class of medications for a particular condition. They go across a whole range of different conditions. And even though at the moment in general practice we're probably not prescribing a lot of them, two things. As years go by, we will be, but our patients will be on them, and either on a Monday morning or on a Friday afternoon, we're, as usual, going to be left with needing to sort out some of the issues related to that. So, again, in general practice, we need to be abreast of what's happening, even though it might not be absolutely all that we do or that we're at the absolute front line of prescribing. Our first presenter this evening is Dr. Damon Langworth, who is a clinical immunologist at Wesley Hospital and Director of Immunology and Chair of Partners at Sullivan Nicolaides Pathology. And Damon's going to be bringing us up to speed on Biologics 101. Please welcome Damon.
Thanks, Joe. So I'm going to give a brief overview of a huge topic just to give you some understanding of what these drugs are. Biologics is a very sort of non-specific term. Really what it means is that these are drugs made by cells. So no longer is a chemist there trying to synthesise things, boiling things over using a Bunsen burner. These things are made in a very fancy bathtub, a bathtub designed to keep conditions exactly the same as much as possible. And so live cells, which have been created, make the drug for you. So for a drug company, once you've done all your work at the start, you just keep your quality control systems going, and these cells exist forever. So they are immortalised cells. So they don't die off unless you don't give them enough food. And so they are created by various techniques, and incredibly cleverly now, using various bacterial enzymes, we can actually edit DNA, but also edit immunoglobulins to make them how we want. So it's site-directed mutagenesis, so in other words, changing and editing, so that it's much like if you thought of building an immunoglobulin molecule with Lego, you can actually change each piece of the Lego with an enzyme. Now, there are some rules. A long time ago, there was a thing set up so that these drugs would be used certain ways and what they mean. So they do actually sort of have hidden meanings. This drug here, muromonab, or it still gets called OKT3, its originator name, was first marketed in 1985. So biologics have been around for an incredibly long time. It's just that they usually were in very niche markets and they were never used outside a hospital. So this drug was invented for transplantation. It prevents acute rejection. And so that was a mouse antibody. Now the trouble with mice antibodies, if you use whole mice antibodies, the second time you give the drug to the person, disaster happens because they've usually sensitised. Much like streptokinase, you may remember that drug used in heart attacks. If you use it a second time, there was a great risk of having a severe allergic reaction. Well, the same thing occurs with that drug. Over time, people have learned or tried to make these agents more human. So in other words, the idea behind that is you have less reactions, so injection site reactions, because the trouble is sometimes you see drugs that work but can't be tolerated because of the injection site reactions or the fact that you make blocking antibodies against them. So originally, antibodies like infliximab, about 50% of people make antibodies to infliximab at 2 years. About half of those are blocking antibodies. So that's a significant number of people who you've invested in treatment, you put them on treatment for their disease, the disease may have got better, but then it stops working because the patient's own immune system blocks these. And that's the big issue with these drugs. So that's a chimeric antibody. That means it's sort of half human and half mouse. Then we've moved on from there to make humanised antibodies. So one which you may be aware of is Xolair, which is trade name is omalizumab. And that is used in asthma and now severe chronic spontaneous urticaria, as well as a few other ragbag diseases. And it is fully humanised. So we know that when you humanise antibodies, you decrease the antigenicity, probably across the board down to about 6 to 8%. Some slightly higher, some slightly lower. It may be that the mode at which you give the drug alters their antigenicity. So in other words, often subcutaneous injections are more stimulatory and IV less, but it's not the same for each drug. So now I've put some more rules-ish because people, drug companies sort of stick to this and then just sort of change things. So you can see there are things used to code in the middle of the drug what the system is used for. It's kind of extra for experts because it doesn't really matter, and if it sounds bad, they'll change the name. They are quite hard to pronounce, things like ixtakinumab and ustekinumab. They're certainly not easy to roll off the tongue. But you can see here, and then the last thing that companies have done have put pegol, so in other words, polyethylene glycol, which is a substance close to antifreeze, on the end, and that decreases the rate at which the drug is metabolised. So it prolongs its half-life. So you might get an agent which you can treat once a month instead of once a week. So in rheumatoid arthritis, a drug called etanercept, you have to really do weekly. But other drugs, certolizumab, which is pegylated, is once a month. And for patients, that makes a difference. So as I said, antigenicity varies with the degree of humanness. However, even a totally human antibody still has an antigenicity of about 5%. So in other words, 5% of patients will make an antibody that blocks the use of that drug. They are usually not cross-reactive to other drugs. So the next drug will work, provided the next drug is not a new thing, biosimilars. So biosimilars are agents which are called that because they are made by a different company and they're trying to make the same drug when they don't know how it was made in the first place. Because that's proprietary information. So they have to bring that to market. Now we know that so far, testing has indicated that biosimilars are identical in action and identical in their blocking antibodies. So if you use a biosimilar, because it's dirt cheap, $10 compared to 1,000 or something like that, you block the original one, the next drug, the biosimilar, won't work. So you are going to have to be abreast, and they are rolling off, as Dr. Denaro will finish at the end, there are large numbers of biosimilars coming. As a lot of these drugs have gone past their patent, so the reason why there haven't been lots of things is it takes a long time to make a biosimilar, and you have to spend all the money to do a study. There are assays for some, so we can measure these antibodies, and that's useful in some. We can measure the drug levels, and that's useful in some conditions. I mentioned that. And so this is just a little cartoon. So this is mouse. In other words, no part of that is human. So in other words, we're really good at trying to make antibodies against the things that aren't us. That's what our immune system's for, differentiate self from non-self. Then with a chimeric antibody, we've just changed the FAB. That's where the antibody binds to the antigen, the target. Then humanised, we use little bacterial enzymes to take out a lot of the DNA, a lot of the protein. And the reason why we do this is bacteria and animals use different glycosylation enzymes. And glycosylation of the surface of a protein alters its antigenicity. And so the target is really down here. The other thing about monoclonal antibodies is they target usually a very specific molecule. Not like, say, prednisolone, which affects pretty much every cell in your entire body. We're now moving on to actually only targeting one cell or even a group of type of those cells, or one chemical. And so the chance that the drug works is usually higher. In some diseases, close to 100% response. In some diseases, much less, only 20%. But they're usually a single target, so their off-target effects should be lower. So you should get, usually, far less systemic symptoms. There are some more rules. Now, biologics is kind of cheated, so we're now using biologics for anything that appears to inhibit an enzyme or interfere in a pathway. They're not really biologics because they are synthesized like traditional drugs were by chemists in a lab. But you will hear these, and they're coming, and they usually do have a lot of off-target effects because they're targeting an enzyme that may just be used more in one disease, but it's still used in lots of other cells. So they often have an array of side effects. There's another group of cells, of drugs called CEPs, which are fusion proteins. So it's where you bind an antibody to a receptor, and you stick that in a person and you kind of mop up a substance. And there are 3 or 4 of those in the market. They also have biosimilars, and so they will have a different trade name, and so you have to be aware of all these things. So these are drugs which are coming to every faculty. Every single specialty area will have a monoclonal, and it won't just have one. So I know in my area in immunology, I know of one pipeline company where they have 30 agents being investigated, and that's one single company. So most of the big pharmaceutical companies have multiple drugs which will come to pretty much every chronic disease that you guys will be involved in looking after. So you are going to have to know what they do, and most importantly, what bad things they can do to people.
Oops, sorry. Great, thanks, Damon. And again, if you've got questions, and I'm sure you will have by now, put them into Slido or hold that thought in your mind. We've got all these agents coming, and that's all wonderful and good, but at the end of the day, it's really about, well, what does that mean for our patients? And our next speaker is Associate Professor Gary Kilov, who's a GP educator and consultant. He's down there in Launceston in Tasmania, so the weather's a bit nicer up here than Tassie, I'm suspecting. Was a founding member of the College of GPs Diabetes Specific Interest Group and a co-founder of the Primary Care Diabetes Society in Australia. It's been published many times in peer-reviewed journals. And what Gary's going to talk to us about tonight is the patient journey with use of biologics. Please welcome Gary Kilov.
Thank you very much, and welcome everybody. I was hoping to introduce you to Mrs. MB, but in a moment I'll explain why she's not here. But just before we get on to that, we have many, many ways of assessing disease severity, disease progression, response to medications. We obviously ask about symptoms, we look for signs, we do investigations, we do biometrics, we can evaluate quite a bit in a fairly logical and scientific way. We also may subject the individual to a quality of life questionnaire to get an idea of how this impacts on their life. But the reality is that none of this really gives us a real insight into how this impacts on a day-to-day basis. Now, Mrs. MB was going to travel with me from Launceston and be here today to be interviewed, but I got a text at 5:30 this morning as I was about to get into the taxi to go to the airport. She was not well. She really didn't feel she could make it. And I know this is true because I saw her 3 days ago when she came to see me and she thought, I'll just come in just as a precaution because I've got a bit of a sore throat, a bit of a runny nose. And I checked her over and I said, look, it's just a virus. I'm sure you'll be fine. I got it very badly wrong. But I do have permission from her to share her story. And in addition to looking after her over the last 5 years or so, we spent a few hours over cups of coffee just chatting about not the medical stuff, not the stuff that we would do during a consultation, but really just talking about her life in general and how this was interwoven with what I'll talk to you about. So she's 64 years old now, but I'm going to take you back to 1996. She was in her mid-40s, busy lady, raising kids, running her own business. Really a very organised, dynamic woman. But then she develops painful toes And the things what she remembers most about that period was that her toenails were going green and becoming ugly. Now, we don't generally ask patients, what are your toenails like? Are they, what colour are your toenails? Now, as you'll see, it is something that would be relevant in this lady. So she sees her GP, and he diagnoses onychomycosis. But he doesn't take nail clippings. And so he treats her for 6 months on an antifungal. And she doesn't get any better. In fact, she gets worse. She's now complaining of increasing lower back pain. She's fatigued. And the term she uses, bone weary. And remember, this is a lady who 6 months, 12 months earlier was dynamic, active. And now she's struggling. And she's desperate. And she's not getting any better from what her GP is able to offer her. She sees a naturopath, a herbalist, and she said, I didn't believe in any of that, but I didn't know what else to do. And of course, not surprisingly, she didn't improve. But there were clues. There were clues to what was going on. She suffered with pretty bad dandruff, and her mum has extensive psoriatic rash. So this really impacted her life in ways that were devastating. So much so that she had to get her husband to help her out of bed each morning. And the thing that she remembers most was this awful fear of the impact this would have on her children. Would her children feel that she was dying? Did her children think she was lazy and just didn't want to get out of bed? And she's counting the considerable cost. She's seeing doctors, she's seeing naturopaths, she's buying pills and potions, and nothing's working for her. Eventually, she seeks a referral. And this is where things change. She sees a specialist, a rheumatologist, and she finds him confident, reassuring, but most importantly, provided her hope. And he did this by means of frank and open discussion. And he gave her a diagnosis that made sense to her. And he discussed the therapeutic options. So remember, we're talking 20 years ago. And she says that she makes a pact with the devil. What does she mean by that? This is what she accepts. And she decides that it's better to be functional now and cop whatever future risk may be involved in taking these medications. And she took lots of them. She took over 20 tablets per day, and this continued for 12 to 15 years. Now, I know this lady very well, and I can assure you that if she was prescribed a medication to be taken in a particular way, she did it. She would have been very adherent to her regime. And she quips that she actually went through menopause 3 times. She went through it naturally, she went through it with withdrawal of HRT, and she actually, an unrelated issue, she was not that long ago diagnosed with breast cancer, so medications related to that. So poor lady has done it tough. And again, the cost, the enormous cost in health, in opportunity, and of course money as well. By now, she has no business anymore. She's given it up. She couldn't keep going. Fast forward to a few years ago when she's offered a biologic agent. And I asked her, how did you feel about this? These agents that are purported to have potentially some nasty adverse effects. And her response was very clear. She said, you know what, I've got nothing to lose. I've been taking all these medications, lots of them, for the last 12 to 15 years, and I still don't really feel great. Yes, I'm better than I was, but things are still not right. Are you worried about it? Were you concerned? She said, absolutely not. She had full faith in her rheumatologist. By now, they had known each other for over a decade, and the therapeutic alliance that they had established was very strong. She had enormous confidence in her rheumatologist. and she's a very positive person. She did not entertain the option of failure. It was just not on the cards for her, or of drug intolerance. So this probably helps too if you've got a really good positive attitude. So the initial experience was, as she said, so I don't know, there's something missing there, but basically she said there were no fireworks. She said, well, more of a fizz than a bang. The medication, the new medication was overlapped with her prior medication, so there was a gradual transition across. And she thought it's not too bad, but a real telling moment for her was when she developed a flu-like illness and developed the normal myalgia and arthralgia. And she said, actually, that's the way I used to feel all the time. So the stuff is working. It's pretty good. And in fact, it got better. Currently, she is on no medication other than the Enbrel for her psoriatic arthropathy. She complains of no symptoms and no adverse drug reactions. So I said to her, look, I'm sorry you can't come with me today, but is there anything that you would like me to share with the delegates? And she said, I've got a few things I'd like you to share. I think you're already getting a picture of this lady, a feel for who she is. To healthcare practitioners, be holistic, be thorough and respectful. And when all else fails, read the instructions, listen to your patients. And we as generalists are good at that. We shouldn't be limiting ourselves to a toenail. That's not what we do. We look at the whole patient. We listen to the patient. She also wanted care individualised, and I guess in some respects the new era of biologics is individualisation. These highly specific and targeted agents that address, and you hear more about the science around some of the other agents that are coming, but may address just one molecule, one target. And she wanted to know if it could be personalised even more than that. Could the rate of injections be changed depending on how she's feeling? To fellow sufferers of psoriatic arthropathy, don't hesitate. For her, it's been life-changing. Very confident and very positive about it. And to the regulators, a predictable and understandable response. Make it easier for us to get it and let us start earlier. And I think you'll hear from subsequent talks that it is actually happening. The idea is of earlier intervention, of modifying the disease early rather than late, is finally taking shape. There are challenges, of course, but hopefully this is going to happen. And we as GPs need to know more about this, need to be more involved, because they are coming our way. Thank you.
Good. Thanks very much, Gary. In fact, not surprisingly, this sort of dovetails into our next talk. And again, if you've got questions, put them into the Slido. You can do that now with the hashtag MEDTalks. Our third talk is about the clinical relevance for GPs today. So again, we've heard about where these drugs are at, and there's more coming. The impact that it can have on an individual patient and changing their lives, and necessarily, not everybody gets the same result, but it shows you the potential. Our third speaker this evening is Associate Professor Ralph Autumn, who's also come from colder climes down in Melbourne. In fact, even coming from Perth, the weather is here just lovely. People really, you're onto something special up here in Brisbane, I'll give you the tip. Ralph is also a GP, an honorary clinical associate professor at the University of Melbourne, sits on numerous boards, expert panels and working parties, and Ralph is going to talk to us about the clinical relevance for GPs today. Please welcome Ralph Autumn.
Thank you. Thank you. Look, I think it's such an exciting area to be talking about and to actually see happening. I've often pondered about how wonderful medicine is. So when I went through medicine, as a GP, I would often see people with things like this. Dreadful conditions have huge impacts on people, both physically as well as psychologically. Managing people with burnt-out rheumatoid, with the ravages of what it used to leave behind. And I looked after patients who had these, and at this stage, there's not a lot that you can do, right? So this early treatment is so important. And of course, osteoporosis, which is something familiar to all of us, and fractured hips. And, we know the devastation that fractured hips can actually mean to a person. So hopefully, with what's happening now, a lot of these will be relegated to the past. So, from my point of view, biologicals are a new approach. They're so specific. Many of them are sort of monoclonal antibodies, but they will be tackling many and multiple diseases up to now that we haven't actually been able to imagine. We're going to hear a little bit more about that later on. But an incredibly exciting and targeted approach. Where I thought I'd start is the top 10 biologicals in America. So Humira, which I'm sure some of you will have been aware of, has been used in a variety of conditions. And just think of the breadth of the conditions that we're treating with each one. Infliximab, and if you can say that very quickly, I'm impressed. But again, psoriasis, rheumatoid, Mabthera, so lymphoma, rheumatoid arthritis and psoriatic arthritis, which we've heard about already. And let me say, that story about the impact it has on people is so important. Lantus, many of you may not realise that Lantus is in fact a biological made in some of those very expensive bathtubs from recombinant DNA. Avastin, Herceptin, it just goes on and on. And of course, Lucentis with its treatment for macular edema, Anavenix, so it goes on and on and on. So now, a lot of these conditions we're not going to be the primary prescriber for, but a lot of our patients will be coming back on these drugs. So this is why it's important to know a little bit about them. But what I thought I might do is talk a little bit about the side effects that you can experience. Now, these drugs, as you heard, the number needed to treat is actually quite small. So on average across the whole thing, it's around about single figures to get an effect. So really incredibly effective drugs. But what about the side effects? Now, as you heard before, the side effects are actually quite low. So even though, if this is sort of a whole broad sort of across all of the biologicals, the odds ratio of getting an adverse event, as you can see, is about 1.28. So if you put that in a number needed to harm, right, so not a number needed to treat, but a number needed to harm, for every 22 people, one will have an adverse event. Okay, it sounds pretty high, but a lot of them are actually quite minor and transient. So a lot of them will be or infections, which we'll talk a little bit more later on, injection site reactions, sometimes infusion reactions, almost like a serum sickness, chills and nausea. For people who've used Prolia or some of the other ones, they'll be aware of that. But when it comes to actually the number of people who withdraw the drug because of the side effect, you come to about 1 in every 26. Okay, so, that's still not bad, but that's a significant amount. And then when you start talking about infection, so a lot of these drugs actually do impact a lot of our, the immunological system. So yes, there is an increase in infections. So serious infections, number need to harm about 108. And of course, reactivation of TB, number need to harm about 680. So, when your specialists first start these drugs, they'll actually be doing a whole lot of tests to make sure these things actually don't happen. And we, of course, need to be aware of things like infections and be on the lookout for them. And interestingly enough, as you do when you talk to specialists before these sort of talks, one of the biologics actually will stop your CRP from going up. So if you're using CRP as a measure of infection or severity of infection, well, those people on that particular biologic will have a CRP of 0, no matter what the infection is. So again, we need to know this, and later on we'll talk about why it's so important to discuss those things. Now, so if you're like me, this is how I sort of looked at the end of all the things that you could do with biologics. It can seem a little bit overwhelming at times. So I thought I'd start with something that you're probably all very familiar with. This is a biologic that we use on a regular basis, and it works. So denosumab, we do know that you have to monitor vitamin D, you have to make sure the calcium's correct. Yes, there was a very rare complication of osteonecrosis of the jaw. We often get people to have a dental check beforehand, and we inject it 6 monthly. Most of you, I assume, would have been using denosumab Prolia in your room there? Yeah. So it's not so unfamiliar. You know, that's a monoclonal human antibody. Fantastic, you know. Teriparatide, which is a parathyroid hormone sort of lookalike. Interesting that, I mean, I've never had to use it as yet, but it's got a great place. So it's, you know, basically used for people who, you know, you think aren't going to do really well or aren't doing very well on some of your other agents. Now, when you talk about number needed to treat, so this is looking at denosumab. So in the group over 3 years, 7.2% had a fracture, so that's a vertebral fracture. You can see you can drop it quite dramatically on using these agents. And even though a 0.5% difference within hip fractures, you know, again, the devastating consequences of a hip fracture, you know, anyone over 70 who fractures their hip, 1 in 3 will die, 1 in 3 will end up in a nursing home, 1 in 3 will end up at home with reduced mobility. So it's a dreadful thing. So if we can reduce it, and so you can see you've almost halved the number of hip fractures that these people are experiencing. So, the message, even though we have absolutely great drugs to treat osteoporosis, it's only good if you use it, all right? So 20%, only 20% of people with an osteoporotic or a low trauma fracture will actually end up on treatment for their osteoporosis. Clearly, we can do a lot about that. We need to be vigilant. We need to get people on these medications to make a difference, because the biggest predictor of a second fracture is having had one before. So again, I think this is one of the critical things. If you want to take one message away from me, we need to identify the people who the drugs will be useful for. But there are other things, you know, falls prevention. So drugs will not do everything. Even though they're wonderful, they will not do everything. We still need to talk about falls preventions, key management when it comes to preventing fractures. Looking at their nutrition, making sure that they're getting adequate calcium within their diet and adequate protein. People who've had a fall, especially over the age of 70, they will lose confidence. We need to be working with them to get them back to their confidence, getting them out of their isolation and getting back into the real world. And that's a significant thing to get going. Monitoring, making sure that they're using their medication, taking their medication and monitoring their osteoporosis and making sure that they continue with therapy. All really critical. So, just a quick talk about teriparatide. Look, I haven't used it yet, but it is available for those people who have really very severe osteoporosis who continue to fracture despite being on an agent. But moving along, rheumatoid arthritis. Now, again, the wonderful thing of talking about specialists, see, I was taught if you get someone in first 6 months of starting their rheumatoid, you have the biggest ability to have an impact on the progression of their disease. I've now been told it's 6 weeks. If you get people now on something like a biologic within the 6 weeks, I have been told that you can almost talk about a cure. Now, this is new to me, and maybe we can expand about that later on in the question and answer time. But to me, you know, it's all about remission, and now I'm talking about cure, which, you know, is a bit mind-boggling. But certainly, we want to get these people into remission. It's really, really critical if we want to prevent that ongoing deterioration of function. You know, I've seen people at the other end, you don't want to be there. So early use of the disease-modifying agents. Methotrexate still forms the backbone, but if we're not getting adequate control, we need to escalate to our, you know, be an advocate for our patients about getting them on appropriate treatment. And yes, we've talked about that increased risk of infections, you know, TB reactivation, and of course, once they're on some of these agents, these immunological agents, you've got to be really wary about giving, or you can't give some of the live vaccines. These are a list of all the agents that you can use when it comes to rheumatoid arthritis. I don't know half of them. But the issue here is that it's critical that the specialists and ourselves have a conversation about what they're on, what we need to be looking out for. Because, you know, they do come to us for everything else, and on a Friday afternoon you don't want to be sort of trying to work out what's going on. Certainly, they need regular blood tests. Most of your rheumatologists will do that. Make sure that we get a copy, of course. Some of these will cause an elevated blood pressure, so we need to keep monitoring that. Mood, people with rheumatoid arthritis, with pain, will often be depressed. We need to screen for it. We know with the biological agents there is an increased risk of infections, and we need to be vigilant for it, looking for things like, if they're overweight or putting on weight because of the steroid they used to be on, we need to tackle that, and of course keeping them moving and exercise to maintain muscle strength. We know people with rheumatoid arthritis have high risk of heart disease, so we need to be vigilant for them. We need to manage the risk factors as well. They are at high risk of osteoporosis, again, which is where we come in. We do a lot of this within our practice. We know if they're a smoker, they're less likely to respond to therapy. So getting them off smoking is really, really important. And this is the really great one. We're the big coordinators, even when, especially when things go wrong. But we will have to manage all of this in a holistic sort of approach. Now, I'm going to stop there because the exciting thing's yet to come. So thank you very, very much.
Thanks, Ralph. I wouldn't put it down that way. I think it's all been pretty exciting and new and giving us pause to think. Our fourth speaker tonight is Dr. Charles Denaro, who's a general physician and a clinical pharmacologist. He's the Director of Internal Medicine and Aged Care at the Royal Brisbane and Women's Hospital and Associate Professor at the University of Queensland. Charles is going to talk to us about the future. And the future to some degree is here, but it's also coming and coming fairly quickly. Please welcome Charles.
Thanks, Joe. Thanks, Joe, and thanks to the organisers for inviting me to give this talk. Now, the future of biologics is a very big topic, and I've only got a few minutes to talk about, so I thought I'd choose just a couple of areas to discuss. And when you think about biologics, you're thinking about often cancer care medicine or autoimmune disease, but there are other areas that biologics are now being used. One of them is cardiovascular disease. Now, this is a patient of mine. She has had 3-vessel coronary artery bypass grafts. She's got a renal transplant for a rare disease called Fabry disease, and her lipids are completely out of control. And she's totally intolerant to all statins, ezetimibe. We've tried every possible regimen we can think of. I've sent it to prominent lipidologists in Brisbane, and we've failed miserably. And I can't give her cholestyramine because it'll interfere with her immunosuppressants. Can't give her fenofibrate. It'll also interfere with her immunosuppressants, and fenofibrates or fibrates in general won't reduce LDL cholesterol very much. So here is a new paradigm. This is the LDL receptor in the hepatocyte. And for reasons that are beyond me, we produce a protein as well called PCSK9. And that protein binds to the LDL receptor and destroys it for some stupid reason. Now, if you can produce a monoclonal antibody and grab it before it binds to the LDL receptors are not degenerated. They maintain, in fact, recycle, and there are more LDL receptors. So here's one of these monoclonal antibodies, and you give this one injection subcutaneously, and you can see it lasts for 3 or 4 weeks, one injection. This is the LDL cholesterol, and it goes down for 3 to 4 weeks as well. And there's 2 on the market at the present moment, hard to pronounce. And they're on the PBS only for familial hypercholesterolemia, the homozygous form. So very few patients can access them at the present moment. And here is a clinical trial using one of them, and you can see it's a very big clinical trial, 13,000 patients in each arm, and these patients are patients who have had cardiovascular disease or ischemic stroke or peripheral vascular disease, and they're all on statins. And you can see that the placebo group are doing pretty well. The LDL's around 2.3, not really a goal. We'd like them perhaps below 1.8, but many of our patients don't get that low. And you can see with the monoclonal antibody, the LDL is through the floor. In fact, for some of those patients, you can't even measure the LDL, and we're not quite sure what that means when they have no LDL for a decade or so. And this is the final endpoint of this study. This is cardiovascular death, myocardial infarction, non-hemorrhagic stroke, and you can see that it reduces those events by 20%, or an absolute risk reduction by 2%. Number needed to treat is 50. Now, at the moment, these drugs cost about $14,000 a year, so this is about $2 million to save one event. But this is a new paradigm, a new way to decrease cholesterol, and you can see that there are a lot of our patients there that aren't at goal or cannot tolerate statins who will need drugs like this. And it's a whole new biology that we did not know 10 years ago. There are substances called small interfering RNAs. You know this thing called junk DNA. 95% of our genome is junk DNA, but in fact, it's full of switches and RNA molecules turning things on, turning things off. Well, you can use them for your advantage. There is a substance called insulirin, and it's in phase 3 studies. Now, I put this cartoon here not to go through it because I don't really understand it, but this interfering RNA binds to the messenger RNA that makes PCSK9 protein, degrades it. So it does exactly the same story as the antibodies attaching to PCSK9. One injection every 6 months drops your LDL cholesterol by 50%. It's a new world. It'll probably cause cancer, but it's a new world. Another cardiovascular drug or cardiovascular where biologics could be used is this drug called canakinumab. And it interferes with one of the interleukins. Now, there's a million interleukins. Who understands them? Probably Damon's the only person that understands them. But 1 beta is very important, so it stops it. It is registered already in this country for some rare immunological diseases. And inflammation is thought to be very important as a cause or precipitant of events in atherosclerosis. And there's been lots of studies trying to prove this, and most of them have been negative until now. And so here is canakinumab in patients, again, with cardiovascular disease or have had non-hemorrhagic strokes. Now, the benefit isn't great. The same endpoint, cardiovascular death, myocardial infarction, ischemic stroke, but it decreases those events by 15%. So not strong, but it still is probably the first definitive trial to show that you stop inflammation, you reduce your further heart attacks. It was largely driven by heart attacks. The number needed to treat, unfortunately, is 156. Last time I looked in the US, it costs $65,000 US a year, so $13 million to prevent one event. But this is proof of concept. We are now stopping heart attacks by interfering with inflammation. Of course, if you interfere with inflammation, there is some side effects. And the same study looking at cancer progression, part of cancer progression is due to inflammation. If you block inflammation, this is placebo here, and this is the various doses of this monoclonal antibody, and you can see that the incidence of fatal cancer is decreased by blocking inflammation. So it's a brave new world that we're seeing. The last topic I wanted to talk about is biosimilars because they're here and now. Damon has already alluded to them, and I wanted to expand on them. Here is, on the right-hand side, Lipitor, atorvastatin. Now, if you want to make a new version or generic version of it, it's not too difficult. But if you want to make a new version of Herceptin, which is used in breast cancer, this is a whole new beast to make. And as Damon has said, if you're a new manufacturer, you don't know how it was originally made because all of that is patented. But the patent for the drug itself has now gone. And there are many biosimilars now on the market and many to come. In Australia last year there were 12. In the UK at the same time there's 22. And there are a lot of the original biologics that you're familiar with are now off patent and there's a whole lot of biosimilars coming. I want to talk to you a little bit about microheterogeneity, just for a short second. All biological systems have inherent variability. So if you're making it in Chinese ovary cells, or you're making them in fibroblasts, or you're making them in some other cell, you're going to get slight differences. Now with the biosimilars, they have the same amino acid background, or backbone. But after that, they get different things attached to them. So you'll have different carbohydrate molecules attached to the protein, glycosylation, or different sulfation, different things that join onto those molecules in the post-translational situation, which will change slightly the conformity of that protein. But in fact, the innovative molecule has also changed, all right? Because the technology has changed over the last 20 years. 80%, 80% of all the biologics in the last have had a manufacturing change each year. And Herceptin of 1998 will be different from the Herceptin of 2017. There are even batch-to-batch differences. So the evaluation of biosimilars is different. For generics, you just have to show that it gets absorbed just the same amount. But, as I've just shown you here, the differences between an original and a biosimilar could be similar to the differences between 1 year to the next of the original molecule. So when we evaluate biosimilars, are they going to be the same efficacy? Are they going to get into the same tissues? If you've got different glucose molecules or carbohydrate molecules on the protein, are you going to get a different immune reaction leading to loss of function or allergic reactions, as Damon has mentioned? What happens if I go from the originator to the biosimilar? And so, more than just the generics, you have to actually do at least one clinical trial comparing the original with the copy molecule to see that it actually has the same clinical endpoints. This is expensive to do, and that's why biosimilars are going to be more expensive than a simple generic, but usually they only have to do one study. Now, the pharmaceutical benefits scheme is out of control. Last year, it increased by 20%. And it's largely driven by all these high-cost drugs. It's unsustainable. In the top 5 most expensive drugs, 3 are biologics. This costs $770 million. And that doesn't take into account the hospitals' costs in the public hospitals. And in the top 50, 10 are biologics. That's $1.5 billion. So even though they're more expensive to make, and evaluation is a little bit more complex than normal generics, they're going to be cheaper than the original biologics. And in fact, when you put out a tender, the original biologic company puts down their price as well. So this will reduce our outlays. It also allows these medications to be used in different populations or different indications where previously we thought it was cost ineffective. But if the price comes down, we can use it in other conditions which might be beneficial. Is it a panacea? Well, I think without it, we are going to be in real trouble with the PBS. It will allow us, if the prices of those drugs go down, to introduce new drugs. In fact, there's probably in this decade 100 new cancer drugs that we're going to have to use. How are we going to afford them? And there are things to consider. If you use infliximab, do an infliximab study in rheumatoid arthritis, and that's the only study you do, will it work for Crohn's disease? The answer is yes, but you have to understand that people are concerned about extrapolating from one indication to the other if you only do one study. There is this concept of A-flagging, which is from the Pharmaceutical Benefits Advisory Committee, who if they decide that the biosimilar is very similar to the original compound, pharmacists can swap from one to the other depending on what deal they're making. And that might be okay if there's only 2 infliximabs, but I think within a couple of years there'll be 10. So a patient could be on 10 different drugs in 1 year, and we still don't know what that will mean. And Damon has already talked about the antibodies. So the future. Is it going to be innovative and exciting, or is it going to be scary and we won't be able to afford any of them in any country. Thank you for your attention.
All right. Well, that's a different mark to finish on. Some famous faces there. All right. Well, we need to set up the chairs, and while we're doing that, we already have a number of questions on the Slido. I think history is sometimes sort of informative here, that we can look at some of these drugs and a lot of them are expensive. They can only be prescribed by specialists and only in certain circumstances. I remember when I was in med school, the then medical registrar on the unit I was on had to apply to Canberra to get very special dispensation to put a patient on captopril. It was about 34 years ago, something like that. In the mid-80s, if you wanted to prescribe Tagamet, people had to have proof of an ulcer, and it was an authority drug. It eventually went over the counter. So price will influence that. All right, now look, we have our first question, which I think is very valid on the Slido. Which I'll press on here so I can get it to work. Now, we heard about you can't give live vaccinations, but what about, do they interfere with other vaccinations?
Significantly. So it depends on what they are. But rituximab, which is a drug used in lymphoma, vasculitis and rheumatoid arthritis, decreases your flu vaccine rate down to about 20%. And so there are now recommendations on when you try and time that. It's actually quite hard because some diseases, the disease doesn't bother to care about the flu season, so it doesn't really, so often you would be vaccinating them after it, and it really doesn't work. They all have some effect on vaccinations, but vaccinations are worthwhile. And now most of the professional bodies have put out recommendations on what you should do for certain vaccines. The live virus vaccine story is actually just medical legal. It doesn't actually have anything to do with reality. Because you can't really give someone an immunosuppressive and go, let's give you this live virus vaccine and see if it kills you. There's no data, but in fact, you shouldn't just assume that to be case. So if there was a measles or mumps outbreak, or measles outbreak, you should probably still have the measles vaccine if you haven't been vaccinated.
All right.
And there's good data on that.
Good stuff. Happy to take a question from the floor. Got to look into the light. Have you got any hands up on the floor? Yes, down the front here.
For Gary, how's your lady's toenails?
Yes, so...
That's a very important point.
Yes, so she's dramatically improved. Of course, not everybody gets that same wonderful outcome, but she's good.
So
She's good.
toenails have grown back normal?
They have. So remember, she's been treated now for, a couple of decades.
So I'll complete that. This was exactly my story. I'm 63 and a half now. And that is what started, just the toenails. And I've never ever had a fungal infection. I sent 3 times, and I'm working with more than two very bright GPs. And we sent in nail clippings, everything, but the mines decided to put me on an antifungal, oral antifungal still for 6 months, even that I did not believe in it. And it's only in one day where, and then it started on my fingernails, which is something you did not mention. And there's no lesions anywhere else. Then it started as arthropathy.
Yeah.
And it's only then when I went to a rheumatologist, and I went to Embro and for 6 months, which was fantastic as far as zero side effects. And no arthropathy at all. I'm back again swimming, doing anything else. I can jump on a jet ski if I want. And however, it did not affect or change the nails. That's why I established.
Yes.
And then I was shifted to Humira immediately after that, as when I was promised that this will really return that. And I took one Humira injection. And I've never had shingles in my life, all the way from cervical.
All right. And thank you very much for that story, and no for everybody else. He's not a plant, just in case anybody was wondering. Anybody like to pick up on any of the it wasn't so much a question, I was just saying thank you for that. Anybody want to make any comments?
Well, I might just respond that clearly Our Lady's story would have resonated with you, and I imagine that there are many other GPs in the audience who would have variations of that, not necessarily themselves personally, but among their own patients. And what you finished off with, I think, was a cautionary tale in the sense that, there's a bit of yin and yang. And I think that's where GPs are going to need to start understanding. There was the very good question about, do they interfere with vaccinations? An important question. We've already heard about the dangers of live vaccines. Where do you make that clinical judgment? And I suspect in many cases, we're not going to have clear guidelines, clear advisories. But this is coming our way, and we will upskill in it. But thank you for sharing.
I'm going to bundle two of these questions together off the Slido, because whilst they're not the same, I think they do tie together. How does being on a biologic affect our assessment of routine infections? And why are biologics associated with immunosuppressive side effects? Because I think those two things, they're not identical, but they sort of tie together. Who'd like to pick up that one?
I guess the beginning biologics, there's two groups, as Charles sort of talked about, immunology and cancer, and often they're kind of the same, in fact, because the drugs for cancer are promoting immunologic attack of that malignancy. But they're going to come to everywhere else as well. So not all biologics are going to lead to increased infection. In fact, some will decrease it. So the new agents in atopic dermatitis and eczema and asthma probably decrease your chance of getting infections. The ones we use now are often older. They've been around for 10 years and they're killing things. And they kill normal cells as well as the bad guys. So you've got to be prepared for some immediate consequences, and shingles, pneumonia, all those kind of things. But it very much is horse for course. So in other words, you need to know about that biologic, because it's not going to be the same risk. So even if you're looking for TNF inhibitors in rheumatoid arthritis, the risk of infection differs from each drug. So they're not the same. They might target the same, but their risks are not exactly the same.
I mean, if you're going to decrease cholesterol with a PCKS9 inhibitor, that's unlikely to increase your risk of infection.
Can I just add something to that?
Yeah.
Certainly from the, just in terms of, we've bundled biologics together because we really wanted to do an introduction to an enormous field. And as you can see, this is growing exponentially. So it is about understanding what the biologics do. And they're going to affect every area of medicine. As generalists, we are going to come across the vast majority of them one way or another.
And so I like to pick up on that question about how can GPs and specialists work together, because to me this is the critical, because the biologic is such a wide variety of medications and their impact. I can remember when starting people on methotrexate, I used to get a nice little sheet from my rheumatologist saying, right, we'll do a shared care approach. This is what I'm going to do. This is what you can do. These are the things we're looking out for. If you see these, this is what you do. What we need is to actually be insisting from our specialist colleagues that we need something identical for our patients who put on these new drugs, because a lot of them we won't have met before. So we need to know what to look for and what to expect.
Right, questions from the floor. Yeah, and the second back row there. Yeah, lady with the...
It's nothing to do with biologics. I think I've got a patient who's got osteoarthritis, and she's wanting to go into the stem cells. What do you think about? I don't know anything.
Hope but not reality. Yes. There's a lot in Australia, through a quirk of legislation, you can give someone's own stem cells back to them without any study, without any knowledge of what you're doing, which is truly quite disturbing. And there are a lot of claims from various countries, Russia and India, and also Switzerland. We have this big stem cell trial, or they say that they're proven, but they're not.
Yeah, even in Melbourne, osteoarthritis is not proven. There are doctors who are working outside the usual evidentiary approach to medicine, and dare I say, making quite a bit of money out of it too.
Yeah, we'll go down the front here.
Just back on the...
Just wait for the mic if you can.
Sorry. Your patient who is on the biological had this sore throat and so couldn't join us today. As a GP, how should we manage that? What sort of investigations, what should we be looking out for? Should we be doing a series of bloods? Should she be on antibiotics?
Yeah, good point. Yeah, look, that's a great question, and because I was about to board a plane, my response text message was, "Please see my colleague today." And And in reality, and again, I think this is also part of Ralph's response to how do we work with, response to the question, but how do we work with specialists? And really, none of this is new. We just invoke the same chronic disease model that we've always used. And that means that chronic disease is a team sport. It's not an individual event. And the members of the team will vary according to the condition we treat. So in this particular instance with this lady, I think she's got a viral infection. I don't think there's anything more than that. But I did want her to make sure that she would be seen today and not delay it until I came back, which is what she suggested.
All right, look, we'll go back to...
And I gather the thing for you would be to follow up, give her safety messages that if things get worse, if you get a really high fever, then you have to come back. You don't wait or you go...
And I think in those patients, well, I always tell who are on immunosuppressives that it should be assumed that you've got a bacterial infection, and you should assume that as a patient. It might not be right, but you should go along and be checked out. And certainly if you're getting a fever for 6 hours, you go somewhere straight away. If it's after hours, you go to the hospital. If it's during hours, to your GP.
So really, I suppose that picks up on the last question there. Are they able to mount a suitable immune response, and is the infection harder to treat? So what I'm hearing is not necessarily harder to treat.
No. Depends. It's different for every agent.
But obviously, if you suppress your immune system with one of these agents, then you might get atypical infections, and the infections might take longer to treat.
Which leads to one of the other questions there. Why are biologics associated with immunosuppressive side effects?
Because that's what we're doing.
Okay, there we go. That's good.
We're targeting.
I like. That's good. We've got simple answers. So the next one, which hopefully is also fairly simple.
Can I just ask you a question? And I think this relates to my patient in particular, and now you've got me thinking. She's been on this agent for a very long time. Her bloods are all fine. Is there a point at which we feel more secure, less concerned if somebody's been stable for a long period?
Yeah, probably. So and most drugs work like that in the immune system. If you haven't had an infection, the longer you go without one, the less likely you are to have one. So some drugs only have short periods where they're risky. So rituximab, the first 3 months appears to be the greatest risk, and after that, even though the drug has immunologic effects, there's no increased risk of infection. But it's quite large in that first 3 months.
Okay. Happy to go back to the floor. I think there was a couple of hands up over there. Yes. Yep.
Just wondering, with the monoclonal antibody-based biologics, does that mean, are they likely only to work on enzymes or proteins that are on cell surface receptors or in the serum? Are they useful against predominantly intracellular enzymes? Do they get into cells, or do they tend to need to be looking at molecules that are on the surface of cells or in the circulation?
They tend to just bind to stuff in the serum or in the circulation, but there are now monoclonals which are linked to toxins. So in other words, the toxin binds to a cell, causes an injury, and you get ingress then of the monoclonal inside the cell. And there's even a radio-labelled toxin, so that it's bind to an antibody. And so in other words, the antibody binds to the cell and irradiates just that cell. So they're sort of tandem drugs, if you like. But you are right, mostly these are cell surface receptors or stuff that's in the serum.
Okay.
And don't forget, we've heard about the interfering RNA, which is now stepping inside the cell.
That's going inside.
All right, well, before we go back to the floor, we'll go back to the Slido. And again, there are two that I think are sort of a little bit tied together, so I'd be interested in comments. One, as a rural GP, we lack subspecialty care such as rheumatology. Can you comment on the health economics of biologics? For example, 3 patients on biologics can employ a full-time subspecialist. And also, there was another one up here. I'm in a country town. When can a GP initiate biologics?
Very rarely.
Okay. Thought that was the case.
There's the two that have been mentioned are the only ones, and and to some extent there it is a cost decision by the PPAC.
But you can probably talk to someone and get to, is it in the, I don't know for sure, but in the PBS rules, if you've discussed it with a particular specialist, then maybe you can prescribe some of them.
No. There are some certain exceptions.
We've got someone who's maybe got the answer at the back.
Yeah.
When I was working in Country Queensland,
Just hold on while we get the...
We'll get the mic over to you.
Sorry, my name is Gihan, one of the GPs. When I was working in Country Queensland, we could always teleconference with the specialist in the city, and then they actually did the script, so that went under PBS.
Okay.
Can I just respond? And this applies to the lady that I've presented. So her rheumatologist is 2.5 hours drive away. And so he would like to see her every now and then, and she's happy to make the trip. But the majority of the follow-ups are by teleconference. So he'll guide me if I have particular concerns. So we work very well together, and we can, most of the time, get away without her having to do the 2.5-hour trip, which is, in reality, a full day round trip.
Okay. Question there. Let's see, on this side as well. Yep.
I was interested in your study showing anti-inflammatory decrease in cardiovascular disease with the anti-inflammatory effect. As we don't understand dementia, but dementia, there does seem to be an inflammatory component to dementia. Has there been any studies on biologicals in early dementia, and is the blood-brain barrier a problem with that?
Well, I don't know the answer to your question, but the blood-brain barrier would be a major problem of getting a large monoclonal antibody into the brain. Just won't get there. So you'd have to have a very small molecule, interfering RNAs maybe.
There have been studies, and they initially were encouraging and then they failed. So people have looked at infliximab, which actually does, often with dementia they have an abnormal blood-brain barrier, so that you actually do get decent penetration, but they don't have effect. In fact, what you can get is serious side effects, because with the TNF inhibitors you can get demyelinating syndrome, a la multiple sclerosis. So they definitely do have effects. There was another trial looking at anti-tau, so in other words, trying to break up the tau deposits, which doesn't work. But people are trying, trust me.
I might go back to the slide. I'm not sure there is an answer to this question, but I think it's still worth posing. How can we prepare for the influx of these medications?
Yeah. Well, I think obviously clearly communication from the specialist to the GP about that drug. It might be the one patient that GP ever sees that ever receives that drug for some of these diseases, and there's no way you can be an expert, but you should be given information. I can make a bit of a plug for the Australian Rheumatology Association. Every single biologic we have, in fact, every single drug rheumatologists use has an online free consumer information page on it, and it's all you need to know as a doctor, basically, as well. Okay. So that every single drug is available online with a 4-page printout written at age 14, so that it's actually been vetted by librarians and educationalists, so that everyone can understand about the drug.
Okay, we'll go back down to the floor. You have a question there? You ask one question. Do you have any on this side? I feel like I'm ignoring this side of the room. Have you got any questions on this side?
No question.
No? Not. We'll go to the next row there.
Yeah, I just want to ask, since the biological do affect inflammation, like CRP, for example, in infection, is there any effect on fever, such that you can see a patient with overwhelming infection with no fever?
Yes.
Is it possible?
The answer is yes. So particularly with a drug called tocilizumab, drug used in rheumatoid arthritis, and may have some other indications soon. But it was the drug we were talking about before, it makes your CRP normal. It decreases your chance, doesn't block fever completely, but reduces it. So, and the same thing with TNF inhibitors. TNF is produced by the body to make fever, that's one of its actions, so they may look less sick. Initially, the TNF inhibitors were actually invented for sepsis. So they were given in very large studies which showed that they increased the chance of you dying from sepsis. And that was the reason why they were originally invented, not for rheumatoid arthritis. And so we know they have those bad things, and so you have to treat people as if they might have a very bad infection. And the patient needs to know they can't sit at home with a fever for 2 days thinking, oh, it's just a virus.
Wow. All right. Again, I think this is hopefully fairly simple. One is proteins. I presume these biologics all have to be given parenterally.
Yes.
That's all correct. Good. Nice to get through that one. This one might be a bit harder. When do you use biologicals?
Well, if you're an American and you're one of the 40% that has healthcare, then rather bizarrely, you can get it for indications that you really don't need it. So that a lot of these drugs actually only work when you've got bad disease. So that if you compare methotrexate to TNF inhibitors, if you've got mild rheumatoid arthritis, which does exist, it's a real thing, you don't do better being given a TNF inhibitor. You do better given methotrexate. So it depends. Unfortunately in Australia, to be honest, in autoimmune disease, the PBAC make up their recommendations with nothing to do with the clinical trials. So that we're limited to giving these drugs with 20 or more swollen tendon joints. There's no trial showing that, they just decided that was the number. So I'm not sure how you're less disabled at 19 joints compared to 20, but you can see the burden of proof is actually very high. Now that's a cost issue, and as Charles mentioned, the costs are enormous, and the costs are really in short-term in cancer and long-term in autoimmune disease. Because if you meet a lady who's 23 who's got rheumatoid arthritis who ends up on a biologic, that's a lot of years, and they will make you live longer. So that's a lot of years left, and you're dealing with a $14,000, $15,000 a year drug.
And the other balance is a monoclonal that costs a fortune but gives you 2 months of extra survival for a cancer. It's a very difficult decision to make.
So if I'm looking after a person with rheumatoid who's been stable on methotrexate, who's rumbling along, when should I be agitating?
A functional impairment.
Okay, so
don't use the hard metrics. Use the easy ones. Can you still do what you used to do? Have you needed to change what you do, and what can't you do now that you did before? And there are ways and means of squeezing joints.
I thought that was the definition of ageing.
I love that. Right, have we got any more questions from the floor? Because we certainly have more on the Slido. Anybody got their hands up? It's hard looking into the light. No? All right. Look, I think we've sort of alluded to this. Can they cure the disease? Sort of heard we don't really know, but it might look encouraging. Is that sort of, in rheumatoid, I think we sort of said maybe. Jury's out, I suspect.
They probably, depends what type of rheumatoid. Seronegative rheumatoid arthritis, you can probably be cured off drugs. Seropositive, there's no good evidence that you can. The disease just comes back. It may be that if we treat very early, and these studies are being done, that we can suppress the disease so that you don't need to be on a biologic anymore, and you can just be on methotrexate or similar agents. So it might be a cheaper cost with a better outcome. And the infectious risk of a TNF inhibitor, most of them double to 2.5 times your risk of infection. Methotrexate's about 1.3-fold. Methotrexate's a really safe drug. It's safer than non-steroidals.
Right. Well, speaking of safety, that brings us to the next one. What about use in pregnancy?
So this is actually pretty well studied. There's now an excellent world group in pharmacology, and I can't remember the name of them, but they look at all people exposed to drugs who are pregnant. Because as you know, there's no data collection, so they try and collect incident reports. So we know that TNF inhibitors appear to be safe. The risk is not to the mum, but it's to the baby. And if you can, you stop them in the third trimester. Because the risk is that you get infection in children because the levels can be present for 6 months. You can't give BCG, not that we would to normal babies, but Aboriginal babies in Northern Territory given BCG. If you give BCG to a mum who is on infliximab, the kid can die from overwhelming BCG. But there are a few things like that, and most of these agents are surprisingly safe in pregnancy, which is not an ad to use them in pregnancy, but they are surprisingly safe. And often we do not have the luxury of stopping these agents.
And interestingly enough, the other way, I've had people with quite severe Crohn's who have been put on a biologic who suddenly became fertile from being infertile and then managed to conceive. So it is something we need to be aware of, because she thought she was totally infertile. She was told, but the drug actually, with the suppression of the inflammation, she fell pregnant and did really well, let me say.
Okay, last round, as it were. I will take a question from the floor, and very quick answer, because there's one more that I'd like to pick up from the Slido if we have the time. Yeah.
I just don't know how much detail you go into to tell people about this, possible side effects of biologics. When Prolia first came out, I put a lady on Prolia, and within 2 weeks she developed a severe hypokalemia, and her potassium was only 1.8, and she was hospitalised, requiring IV potassium infusion. Could never find that side effects on the product information.
Well, you only legally you only need to tell people things about 1 in 1,000. Anything less than that, unless it's really bad, you're going to be going on for the rest of your life. To give you an example, on the methotrexate product information that comes with the drug, right at the bottom, the last one says death, which a patient once pointed out to me, and I was shocked. And now every patient I put on methotrexate, I say, don't read the product information, read this instead, our own rheumatology information. The list of possible human side effects is about as many as humans on Earth, I would think.
Yeah. All right, we've got about probably 30 seconds to go. Is it possible that there be more and more of these drugs to be on too?
Yes, I've done that already.
All right, well, look, we've just bang on time. So, look, I think at this point, I'd like to thank our speakers very, very much indeed. And I think we'll wrap up at this point. Hopefully you want to hang around and chat and network and come and chat with any of the speakers. Thank you very much for your attendance in person, and thank you to everybody who's been online, and enjoy your Saturday night.